Good afternoon, everyone, and thank you for joining us for this week's National Bleeding Disorders Foundation Wednesday webinar.
Since 1948, our foundation
Sorry about the impromptu music. It was not intended. My name is Fiona Robinson. I am the series host. Today's webinar is an update on federal telehealth policy. Please feel free to ask any questions you may have throughout the presentation by using the Q&A feature at the bottom of your screen. We will monitor these questions as they come in, and I will put them to our speaker at the end of their presentation. This webinar is being recorded and will be available to the community beginning on Friday, September 29th. Today, we are joined by Kyle Zebley, Senior Vice President at the American Telemedicine Association and Executive Director of ATA Action. I'd like to thank Kyle for joining us today and turn things over to him now to get us started with his presentation.
Thank you so much, Fiona, and I really appreciate the honor of being able to speak at this webinar today and to try to give an overview of some exciting developments that have happened over the last couple of years in regards to telehealth policy. And while I'll mostly be focusing on the United States and federal policy, I would just suggest that I'm happy to answer any questions as folks think about them as I go through some of these slides. Happy to talk about not only federal policy, but also state policy, and also think about how this applies to international policy as well, because a lot of the lessons learned, in particular in the last couple of years over the course of the COVID-19 public health emergency, have been lessons learned that apply across the world, around the world, across our country, with other developed countries and developing countries as well in terms of expanding access to virtual care services. So happy to engage on anything that I might be able to shine a light on from our perspective. We really appreciate being able to speak to you today. I have been with the American Telemedicine Association for more than 3 years, but believe it or not, we're actually celebrating our 30th anniversary as an association this year. We were founded back in 1993 during the early pioneering days of what might have been possible at that point in time for virtual care services. And it's really been an amazing journey for us to try to proselytize the healthcare community of the need to make sure that folks have access to care where and when they need it. And that's really what we're trying to do. We don't really try to slice and dice by modalities or by technologies and try to very narrowly define what telehealth is. To us, telehealth is the ability for providers to deliver care to patients when they're not physically together and using technology in order to furnish those services. The ATA is a very interesting healthcare association in that we really represent the width and breadth of the healthcare community. So yes, of course, we have virtual only providers and vendors, the folks that you might, and the organizations you might think in your mind's eye constitute an association such as ours. But we also have hospital systems and health systems with significant brick and mortar presences. We have commercial payers. We have academic medical centers. We have medical device manufacturers, pharmaceutical manufacturers as part of our membership, and just about everything else in between. So organizations that range from totally virtual to organizations that are still primarily brick and mortar, but are increasingly delivering virtual health services. And I have the great pleasure, I'll also say, as Senior Vice President of Public Policy, to try to synthesize the diverse perspectives of our Big Tent membership into developing policy principles and policy positions on a whole range of issues important to our very diverse community. I think the biggest thing to really level set before we go on is to think about, when talking about federal telehealth policy, where things stand now in 2023 as compared to what was the case prior to the onset of the pandemic. So a couple of things to keep in mind. prior to the beginning of the COVID-19 public health emergency, as put in place by President Trump and as kept in place by President Biden until May of this year, you were required to be physically in a defined rural area and within the four walls of a provider's office in order to have access to reimbursable telehealth services in the Medicare program. What was very forward-looking and indeed arguably progressive in 1997, when Section 1834M of the Social Security Act was passed in enabling some access to virtual care services, obviously by 2020 had become extremely outdated. And so when the Trump administration, working on a bipartisan basis with members of Congress, came to the telehealth community, came to the American Telemedicine Association in the early days of the pandemic, thinking, how are we going to maximize access to virtual care options to keep folks that are in non-emergency situations out of doctors' offices and out of hospitals? At the very top of our list was a request to remove, as best possible, the geographic and originating site restrictions embedded in law. Congress granted the last administration that authority. And I'll talk why in another slide as to why that's still in effect, but it's still time limited. So those were huge obstacles that have been removed since the onset of the pandemic. Beyond just physicians, another area of advancement that has been made during the public health emergency was allowing a greater set of providers to get covered and reimbursed for telehealth services. For instance, physical therapists, speech therapists, occupational therapists, nurse practitioners, physician assistants are just some areas and examples of more provider types that were enabled to get covered and reimbursed through the Medicare program, the biggest lever of authority that the federal government, the U.S. federal government, can pull. Those expanded provider types were expanded by pandemic era policies. That continues to remain in effect. We are very supportive of all Americans, not just those with means, having access to telehealth services. That's why we are so engaged in the Medicare program, which of course is open to every American 65 years and older. At the front lines of delivering care to underserved communities include two unique federal programs, one federally qualified health centers, the other rural health clinics. And through the Medicare program for Medicare beneficiaries during the pandemic, they have been able to have coverage and reimbursement for telehealth services delivered to those patients. That's been a huge benefit. At the end of 2020, Congress, 6 months or so, 9 months into the pandemic, Congress made permanent telemental health in the Medicare program. And that was a really welcome advancement because obviously telemental health is something that is done very well and very successfully via virtual care. But unfortunately, it came encumbered with a concept that I'll go on into further throughout this presentation, came encumbered with these in-person requirements. In the context of telemental health in the Medicare program, it said that if you're going to be eligible for this service after the end of the public health emergency, you are going to need to go to a mental health provider in person prior to establishing a virtual relationship with that provider. Here in the United States, we have a tremendous shortage of mental health professionals. There's no clinical need for in-person requirements. Indeed, we believe that they are clinically inappropriate barriers to care. And so while we were glad at the end of 2020 that Congress took this step towards permanence of an aspect of the expansion of flexibilities during the pandemic in the area of telemental health, we want to make sure that this in-person requirement is repealed and that it is never repeated for other services because we think it unduly restricts access to appropriate care. Another thing that's come about during the pandemic, still in effect, is the ability for audio as a technology, as a modality of care to be offered to Medicare beneficiaries. This is as old as the telephone, the ability to communicate with your provider, with your doctor, with your physician via telephone. But it hadn't really been very robustly covered or reimbursed at all because of restrictions in the Medicare program. For geographic, socioeconomic, demographic reasons, this is the only way for many Americans to receive access to virtual care services. In particular, as we think about our Medicare beneficiaries, those 65 years and older, this is the only way that they're comfortable with it. And so we want to make sure that that is maintained. So a couple of other things that have come about during the pandemic that have been very important and that were levers that the federal government was able to utilize within its existing authority was the ability to prescribe controlled substances remotely. We'll get into the history in a few slides. In essence, this has expanded the number of Americans, many of whom had been underserved or left behind by the healthcare system before this flexibility took effect in 2020. So it has enabled those Americans to have access to care that's appropriate for them, that really has broken down those geographic barriers and other restrictions that have led to appropriate access. So we want to see that made permanent. It still is in effect. Another provision important to us is this concept of telehealth as an accepted benefit. Accepted benefits are oftentimes the difference of some access to care and no access. This whole concept of accepted benefits is really a hangover from the Affordable Care Act debate about 15 years ago. But this has expanded access to care for employees that might not be receiving healthcare benefits in the United States otherwise. And we want to make sure that's made permanent. That was brought about during the pandemic. And then finally, very uniquely in the Medicare program as a forward-leaning experimental program, there's this concept that's been put in place that's really at the cutting edge of what's possible via virtual care using remote monitoring services and some other capabilities. We can have remove patients that are convalescing in hospital rooms, get them back home, connected to these devices, monitored by the hospital to end their convalescence in a place they're most comfortable with. That's called the Acute Hospital Care at Home program, and we want to make sure that that momentum continues. So just want to lay of the land as to what happened during the pandemic, what the Trump administration put in effect, and what the Biden administration working with Congress has kept in effect, largely speaking. There are some exceptions to that. Congress, it's not a secret to say, is a little bit dysfunctional. Washington, D.C. doesn't quite work the way it should via what's called, usual order, the normal order of things. And that's true even in an area that's extremely popular, very bipartisan, that had support from the Trump administration, that gave way to support in the Biden administration. And so over the course of the last several years, I've been trying to educate policymakers and convince them to make a lot of those flexibilities on the previous slide permanent. And very classic, congressional, in a very classic way in terms of how Congress acts. They determined that it was wisest at the moment, for a few reasons I could talk about, to extend these flexibilities forward so that there was more time for studying what it will look like to make these policies permanent in a non-pandemic era. And they did that in this big, massive federal spending bill that was passed at the end of last year in December, right before the Christmas break. And if you look back at previous years, this is just about always how a lot of things get done in Congress. You really catch a ride on a moving legislative vehicle, and you build the support that's needed prior to that vehicle coming out at a pretty last moment during a moment in time when Congress's back is against the wall. That was the case here. We had prepared successfully for it. We were able to make sure that a tax provision for high deductible health plans as it affects the ability for you to use them for telehealth coverage, we made sure that was extended until the end of 2024. So at that moment in time, that had given us 2 full years of flexibilities for that tax provision that came about during the pandemic. We were able to extend all those Medicare telehealth flexibilities, in essence, till the end of 2024. I think, again, on the road to permanency, but it was a way for Congress to kick the can to continue to study. We are able to make an extension happen for that acute hospital care at home program, that forward-leaning, cutting-edge program that is really taking the fullest advantage of what's technologically possible now. What we weren't able to do, for complicated reasons I'll get into in a moment, was include any action on the congressional front on continuing this waiver for the remote prescribing of controlled substances. And then we also weren't able to get Congress to act on telehealth as an accepted benefit. The former is complicated, and it deals with a kind of separate legislative history outside of, largely speaking, outside of the context of the COVID-19 public health emergency when we talk about remote prescribing. When we talk about telehealth as an accepted benefit, while we enjoy and appreciate our bipartisan support, this is one area where really some fundamental philosophical opposition with the whole concept of accepted benefits coming from, in particular, some of our Democratic friends of the aisle, that's led them to be hesitant to move forward on doing anything to extend or make permanent this concept of telehealth as accepted benefit. And so we're working right now to see if there's some legislative path forward on this issue, because again, in our mind, it's a difference between employees that wouldn't have received care otherwise having some access to care versus no access. And not as perhaps some of those that are opposed to this provision believe, it being some access to care versus better and perfect access to care. But it's a big priority for us because we were not able to achieve an extension at the end of last year. We'll just pause for a second. The Medicare program, in particular Medicare Part B fee for service, is again still the biggest lever that the federal government can pull when it seeks to influence health coverage policy. By and large, just to think of it here in the United States and our very federalized system, Congress has control over Medicare Part B and has instructed the Centers for Medicare and Medicaid Services to come up with an annual regulation every year as to what Medicare Part B will cover and the degree to which it will reimburse for services. So very much analogous in other countries to government-run insurance models. So that's a big lever that the United States federal government can pull. They have spooled off for many beneficiaries, and you can decide as a Medicare beneficiary which one you want. Do you want Medicare fee for service Part B, classic Medicare that's been around since 1965, or do you want Medicare Advantage, Medicare Part C, which enables you to choose private sector options to deliver Medicare funded services, and for purposes of telehealth, those plans, those private plans in partnership with the Medicare program, already had a lot of flexibilities even before the pandemic to cover telehealth services, and they've really robustly covered it. You can try to influence Medicaid policy, but under a longstanding practice, Medicaid is really a state-based state agency determination as to what those states are going to cover and reimburse for services to include telehealth. So putting aside those programs, putting aside the Veterans Administration, which is really important, but which has tremendous flexibilities to cover and reimburse for telehealth services, the biggest way that the federal government can influence what payers are going to cover is to set the standard in the Medicare program, Medicare Part B, and to set that standard through the annual physician fee schedule. And you want to influence the physician fee schedule if you care about what other payers are going to do it, because it really does set the standard for what other payers are going to cover and reimburse, even at this date and time, even after the creation of Medicare Advantage. What we saw in this year's calendar year 2024 physician fee schedule, which was unveiled over the summer, which we're still waiting to see finalized, and what's going to set in stone what Medicare will do for Medicare Part B beneficiaries in 2024, was really a positive continuation of actions that have been taken in the past, and also an encapsulation of what Congress was able to accomplish in that in that spending bill at the end of last year that I talked about last slide. So all those Medicare flexibilities, those can be trusted and counted upon to be covered till the end of 2024. We have higher rates of reimbursement for most telehealth services in Medicare. Those higher rates that have been set early in the pandemic, the so-called non-facility rates for most outpatient telehealth care, those will continue till the end of 2024. That wasn't a sure thing. That wasn't a given. So we were glad to see that happen. The ability of a supervising physician to instruct other providers via telehealth for purposes of direct supervision, really favorable item that's come about early in the pandemic, really important for academic medical centers, for instance. That continues till the end of 2024. Expanded this physician fee schedule, expanded the number of viable therapists that could deliver care services via Medicare, the Medicare program. It's expanded the ability of remote monitoring devices that often are monitoring either physiologic data or therapeutic data. We've had a forward march in a positive direction for RPM and RTM over the last several years. That continues to be reimbursed effectively and is now going to be able to be offered by those federally qualified health centers and rural health clinics that are on the front lines of delivering care that I mentioned a few slides ago. We have seen a continuation of the Medicare Diabetes Prevention Program. While it doesn't allow for virtual-only organizations to receive reimbursement through this, you still need an in-person component. It is a positive forward-leaning movement in that direction, for very important for our diabetes patients, of which a disproportionate number of Medicare beneficiaries are living with. We have expanded and kept in place a number of codes, CPT codes that are developed by the AMA and that are covered by payers, including Medicare. We've been able to see a permanent set of codes added to the physician fee schedule that we can expect to be there in years to come. We've added new providers, marriage and family therapists and mental health counselors to the number of providers that can cover and get reimbursed for telehealth services, which is a huge plus. And then for those Medicare beneficiaries that are in opioid use disorder treatment services that are furnished by opioid treatment programs, they have allowed the use of telehealth to initiate buprenorphine, the use of buprenorphine to treat opioid use disorder in these programs and to get covered and reimbursed by Medicare for the work done in that area. And again, if you look at the tremendous problem with substance disorder issues in the United States, this is a really needed and favorable step in terms of meeting those communities where they are and where they need help. A couple of things that weren't addressed that are big priorities for us that we're concerned about. One is this so-called Box 32 issue that requires a divulgement of the provider address on a CMS reimbursement form. Complicated, very bureaucratic sounding issue, but it's really very simple. What has happened during the pandemic is we've had a huge expansion of coverage and reimbursement for telehealth services for all the reasons we've talked about in the last few slides. What Medicare is saying is that at the end of this year and starting January 1st of 2024, if you are a Medicare provider, you're going to have to divulge the physical at-home address to Medicare. And this is information that could easily get out to patients. And what we're concerned about is the safety and security and privacy of our Medicare provider community, many of whom are delivering care from the privacy of their own homes. Obviously, we don't want anything to go sideways for our providers in the Medicare program. We don't think there's a need for it. We think you can divulge the address of your primary employer in order to satisfy any kind of oversight or regulatory needs of the Medicare program and of Centers for Medicare and Medicaid Services. So we hope they rethink this. The physician fee schedule would have been a great place for them to hit pause and not proceed. But alas, they missed this opportunity. But it's not too late for them to use their regulatory authority to make sure that our providers are adequately protected. And then for remote monitoring services, while we've seen an expansion of remote monitoring services in the Medicare program over the last several years, while we've seen them move beyond just covering remote physiologic monitoring devices to include remote therapeutic monitoring devices, we are very concerned about some of the restrictions placed on these devices that have not really envisioned a whole host of clinical use cases that would allow for their deployment in the betterment of the health of the Medicare beneficiary in question. Namely, there are these requirements that you have to generate 16 days worth of data in a given calendar month in order to be reimbursed by Medicare. So you basically have to be collecting data from that device 16 days in that 30-day window in order to get reimbursed. We don't think that is necessary. We think that's unduly restrictive. We don't think that has taken into account all of these other medical encounters that could have allowed for the deployment of these devices. That's a big part of our letter to the physician fee schedule that's on americantelemed.org for your review and at your leisure. That will really go into the ins and outs of our response, our 12-page response of the physician fee schedule. And so that's something that continues year after year to cause us some heartburn. So what telehealth waivers, given all things that were made permanent that were extended in that bill, and all the things that the physician fee schedule put into effect through this latest PFS, what waivers ended as of May 11th when the public health emergency ended? The waiver of cost sharing, which meant that you didn't have to do copays prior to the pandemic for virtual care services, that waiver has ended. The ability for telehealth platforms to not have to comply with Health Insurance Portability and Accountability Act rules, HIPAA rules, mandating patient privacy in regards to their health data. That waiver of HIPAA had been in effect for 3.5 years. That wasn't continued after the end of May 11th. The allowance by the Medicare program through regulatory means to bill and get reimbursed for new patients established via remote monitoring, that has ended. You have to be an established patient. You have to be being treated for something other than just what you are being, beyond just having to use the remote monitoring code. You have to be treated for some other code in order to be eligible for remote monitoring devices moving forward, now that the public health emergency's ended on May 11th. And the ability to do the hospital without walls program, so-called, that had been in effect since the early days of the pandemic, that did not continue either. I thought it important to go a little bit deeper on something that's beyond the Medicare program that has a huge effect on millions of people's lives, something that the federal government did early in the pandemic. So in 2001, there was a young man by the name of Ryan Haight, a California school student, who unfortunately got his hands via the internet on controlled substances that he should not have had. And this very unfortunately and very tragically led to his very premature death. In response to that, Congress, years after his death in 2008, passed what's called the Ryan Haight Act in memory of him. And at that time, Congress imposed a blanket in-person requirement in order to establish a provider-patient relationship for purposes of prescribing controlled substances. At that same time, in 2008, with the Ryan Haight Act, Congress envisioned the creation of a so-called special registration process. And this special registration process would allow for licensed medical professionals in good standing to register with the DEA, having divulged information the DEA would determine through the rulemaking process is necessary in order to clear them to establish a prescribing relationship with the patient. And again, controlled substance is anything scheduled 2 through 5 in the United States as designated by the DEA and informed by clinicians and medical professionals, in particular, for instance, at the Department of Health and Human Services. The DEA has enforced the in-person requirement in the years leading up to the pandemic, but they had never developed a special registration process. Why? I think there's probably a number of different reasons that we can speculate as to why DEA never followed through with a special registration process. Perhaps they never wanted the authority from Congress to begin with, as they see themselves more as a police-making agency rather than a health agency. They're really all about getting drugs, in particular illegal and illicit drugs, off the street, not enabling access to care. Nonetheless, as we came to January 2020 and the pandemic came about, and again, the administration and the federal government and Congress were asking telehealth advocates, what can we do to maximize access to remote care? We obviously said, please waive that in-person requirement so that you can have that appropriate level of access for a whole host of clinical use cases of these controlled substances. The DEA waived the in-person requirement, and that has been in effect now since the beginning of the pandemic, 3.5 years. Back in the spring, in late February, they came out with a set of rules that they sought to take effect prior to the end of the COVID-19 public health emergency on May 11th. And when the telehealth community, including us here at the ATA, saw these rules, we were very concerned. While they were more workable than a lot of the blanket restrictions that were in place prior to the pandemic, at the end of the day, it still required in-person visits, which don't allow, that are clinically inappropriate barriers to care that don't allow for the full benefits of telehealth. So we said as much, and 38,000 Americans almost uniformly agreed with us in response to the rules that the DEA put forward at that time. To the great credit of the DEA, they hit pause, they pulled back on those rules, and they kicked the can for 6 months until November 11th of this year to reassess. Over the summer, towards the end of the summer, they announced that there would be a listening session in September of this month, where when they made that announcement, they said, not only are we going to do listening sessions to think through how to do this, we're also going to actively consider a special registration process. In the rules that they unveiled at the end of February, beginning of March, they had dismissed out of hand the ability to do a special registration process, saying, in essence, it's too complicated. Now they're actively considering a special registration process, and we are hoping that it's going to be workable enough, flexible enough, and as close as possible to the current status quo to enable appropriate care. What are the type of treatments that are being done now under the flexibility, under the in-person waiver? You've got care for those that are seeking substance use disorder treatment or opioid use disorder treatment. So prescriptions in that regard, for instance, of buprenorphine or Suboxone. You have mental health stimulants as prescribed by psychiatrists. You have testosterone, for instance, for those that are seeking care and that require that to include gender affirming care. A whole host of other use cases of really vulnerable Americans whom the healthcare system hadn't been serving previously. They've had some access to care now over the last 3.5 years. What the telehealth community is saying is maintain that status quo as best we can moving forward. Don't go backwards. We're hopeful that the DEA will take this as an opportunity to come up with new rules in the coming weeks that will really hopefully sketch out what that permanent foundation for remote prescribing of controlled substances will look like moving forward. We won't belabor this too much because it is again something I've spent a lot of time already talking about. But we've had a number of listening sessions. We put out a number of documents that are up on americantelemed.org that you can take a look at. Really, I think are very thoughtful recommendations to what a special registration process should look like. Very thoughtful feedback in regard to the whole question of what we found to be problematic about those rules that were in draft format earlier this year. We met with countless congressional offices. We've generated a lot of media. We actually even did our own paid media through our advocacy arm that I lead, ATA Action. We have really generated, I think, a lot of thought-provoking areas for the DA to consider when they come up with a permanent framework. Just being mindful of time, I did want to go through a few other issues, very important, very timely for the telehealth community right now. And in particular, this is in the area of data privacy. We have recently unveiled on our ATA website and to the media a set of health data privacy principles that the telehealth community through the ATA really wanted to offer some guidance to policymakers on. When it comes down to it, one of the overall takeaways that we're really hoping to see occur is that the federal government will update its policies in regards to health data privacy, perhaps updating HIPAA to take into account the degree to which we now have virtual care options in this country and the degree to which Americans are receiving those virtual care options. We seek that in order to enable organizations to have some degree of consistency to deliver care to Americans across state lines. We'll talk about this in a slide or two, but essentially what's happening now in the absence of a new federal framework is that states are going their own direction on this area, and they have the authority to do that, but it really makes it very difficult, particularly if states are particularly at divergence with each other. So it makes it very difficult to deliver care and increase options for Americans. We also lay out a very clear definition of what consumer health data is, which is a prerequisite in order to start regulating it. We talk about the importance of having carve-outs as states consider new policies for HIPAA, which has been around since 1996 and which is now trusted by the American people. We talk about the right of consumers to know what they're giving up in very clear, plain English, what they're agreeing to when they enter into virtual-only arrangements with telehealth providers. And that, of course, is also consistent with the whole concept of consumer consent and the acknowledgement as to what might be done or not with the sale of data and the ability to opt out of that sale. And then when we talk about enforcement of data privacy principles, we ask that it not go down the civil route for such a new area, and then instead state attorneys general be empowered, or in the case of a federal update, the Department of Justice and other regulatory agencies be empowered to enforce laws rather than opening up providers to a whole host of civil action that again will lead to, in our mind, less choice and less options for Americans. A number of states have done comprehensive telehealth bills. These states in orange have enacted those kind of comprehensive data privacy bills that include but are not limited to health data. And also in purple here, we see a number of states having introduced legislation but not followed through on passing it into law. States in gray are the outlier. It seems clear to us over the course of these 2023 legislative sessions, starting with California a few years ago and most actively during this year. Most states are trying to update these laws in the absence of the feds taking their own approach. We have seen health data specific pieces of legislation that have been introduced, not necessarily passed, but introduced in a number of states. And we list the 3 states where those comprehensive health data bills have been passed into law: Washington State, Nevada, and Connecticut. A number of other states have envisioned passing laws, but they didn't get through all the way to the governor's desk. States in purple are those states that have not yet taken up any pieces of legislation on this. So again, we've been very active on this. It's a relatively new issue for us, which is why we came up with these health data privacy principles in order to guide our efforts. Our letters on these various bills are up on our website for your review at your leisure. And it just gives you a sense as to the concerns of the telehealth community as state legislators grapple with these really important issues. There is the possibility that we could see comprehensive data privacy legislation move sometime soon. Indeed, last Congress in 2022, a bill that would tackle this issue, the American Data Privacy and Protection Act, did pass through a very key committee on that in the U.S. House of Representatives, 53-2, clearly bipartisan, broad support. And so we could see these laws updated. There has been a hearing so far this year. And then in an absence of federal legislation moving, we could see increasing regulatory actions taken by a variety of national agencies, such as the Federal Trade Commission, which has updated its capabilities of enforcing health data notification breach rules. And they've got, right now it's in draft format. We had a very comprehensive letter to the FTC sharing the perspective of the telehealth community. So we could see more action yet there. So with that, we'll turn it over to Fiona and see if there's any questions. And really, again, so appreciate the ability to talk about some of our big pressing federal priorities with everybody.
Great. Thank you very much, Kyle, for telling us all about these latest developments in the federal telehealth community. And we will go ahead now with our live Q&A. So just a reminder to our audience, if you have any questions for our guest, please just pop them in the Q&A feature at the bottom of your screen, and we will do our best to answer all of your questions. So maybe I can start with a question that came in. You gave a really nice presentation of a lot of the details around Medicare works with telehealth and vice versa. Is this something that's different depending on the type of insurance that you have? Is it a different scenario if you have private or self-funded or Medicaid as your insurer?
Yes, the United States has every type of healthcare system ever tried around the world under one umbrella, and so it gets awfully complicated. Medicare Part B is not the same as any of the Medicare Advantage plans that operate in concert with the private sector to deliver Medicare beneficiaries to those that have opted into them. It's not the same as any state Medicaid policy. Indeed, no two state Medicaid policies are the same. So Washington State's Medicaid policies and coverage in regards to telehealth and everything, really, not the same as California's, not the same as Connecticut's. Commercial coverage, no two policies are the same. And commercial coverage, even if it's the same payer by name, just to pull one out of the hat, Blue Cross Blue Shield. Blue Cross Blue Shield in Michigan is not the same as Blue Cross Blue Shield in another state, even. And no two states' laws in regards to the regulation of commercial payers are the same. And when to make things even more complicated, providers are licensed in the state, must be licensed in the state in which the patient is located in almost every circumstance. And no two states are totally the same in regards to licensing, though you might be able to adopt compacts, but there could be restrictions on a provider delivering certain telehealth services in one state that are not the same in the other. And that's, of course, the predicate before you even get to questions of coverage. And so it couldn't be more complicated. It's awfully hard to track. We have the great pleasure at the ATA of not only covering kind of the headline grabbing items at the federal level and trying to keep track and make sense of that, but also the great privilege of covering all 50 states and the District of Columbia when it comes to the laws and policies that might impact telehealth at that level. Okay. So sorry, long-winded way of saying.
No, that's great.
It couldn't be more complicated.
There's actually kind of maybe two follow-up questions to that. Then one is maybe, do you have any advice for individuals on how they can kind of take a look at what their source of insurance is and how they can then get an idea for what they may have access to in terms of telehealth, how they can inform themselves and advocate for themselves to get access to what they do have access to?
Well, absolutely. Every beneficiary by law and regulation should have access to what's covered in their program. Now, it will look like an encyclopedia in fine print, and so if it's virtual, you might do a Control F to look through what's part of your package. And I must admit, it changes every year. So come January 1, if you've somehow done your best to memorize what are your benefits and what you have access to and what's your copays and the like, it all could be thrown out the window come January 1 in our system. But every payer, be it Medicare, Medicaid, be it the Veterans Administration, TRICARE for active duty military personnel, or all the myriad number of commercial coverage options that we have, they are duty bound to provide to beneficiaries what their policies cover. In terms of advocacy, you've got to be your own best advocate. Obviously, you can work through associations like yours and mine to try to lift your voice and work together collectively. But at the end of the day, having worked in a member of Congress's office for 6 years, nothing is more impactful than a phone call from a constituent to a member of Congress, a phone call from a constituent to a state legislator, letters and emails to governors and the president of the United States, op-eds to a local newspaper, to a national publication. This kind of grassroots effort is always symbolic of 10 other people that aren't stepping up in the way that you are to speak their truth to power as it is. And so it's so important for folks to say, I want to have access to these services. I want to make sure we don't go backwards on that level of access that's been achieved during the pandemic. And for all these things that aren't permanent, we want to make sure we don't go off what we call the telehealth cliff. These are all areas where the grassroots is so important, and where individuals really can make a difference and need to make sure that they follow through on it if they want to be committed to the cause, as it were.
So you did mention, for example, that there's quite a diversity between states, and that some professionals, probably most professionals, are licensed by state. So has progress been made in sort of assisting with care that is provided across state lines?
Absolutely. It's a huge priority for us. It's one of our core policy principles, breaking down interstate barriers to care. And I'd say there's been a lot of progress over the last few years. So one of the biggest areas are so-called licensure compacts. There are a variety of compacts that have been developed nationally by various interested parties that a number of states have adopted. That includes, for instance, for physicians, the Interstate Medical Licensure Compact. For nurses, there's a Nurses Compact and Advanced Practitioner Registered Nurses Compact. There's a compact for psychologists, PsyPact. There are a variety of therapist compacts, PT, OT, ST compacts, for instance. And what these compacts do, if you adopt it, is say that in the instance, for instance, of the Nurses Compact, is truly reciprocal. If you're a registered nurse in Washington State and you're trying to deliver care virtually to somebody in California, you are good to go if those states are part of the compact. And so what's required, though, in order to make that happen, is that state legislatures have to adopt those compacts. There are also other kind of unique registration models that have encouraged out-of-state providers very easily to register in a state in question. There's a real sense of momentum towards making common sense exceptions to strict enforcement of state licensure. If you're a licensed medical professional in good standing for follow-up care, second opinion consultations, care received while on travel or as a student, these types of things. So there is a sense of momentum. The federal government can really play a role in encouraging states, but for a long time to come, I think it's going to really require state legislatures taking proactive action.
We've had a question come in that is a little more specific to the bleeding disorders community. So we have hemophilia treatment centers, and some of them have ended their telehealth visits now that the pandemic has officially been declared over. But those telehealth visits were an important way for people to get access to comprehensive care if they had difficulty to get there in person. And so what advice would you have for these individuals, again, on how to advocate for access to this method of care if the clinics maybe, or the centers may be chosen to discontinue it?
Well, I think alerting the centers of the desire to have access is something that you can pick up the phone or send emails about. I'm not positive who's running those centers, I must admit. So I'm not sure where there might be a public policy overlay in that regard. But obviously communicating the desire as a patient to make sure that services are available virtually are so important for all the reasons I gave a few moments ago. I think as well, this idea of ensuring coverage parity for telehealth, not even getting into questions about reimbursement parity, which is its own concept and own idea. But at a minimum, all payers should be offering, when appropriate, the ability of their beneficiaries to have access to virtual care services, so that we're trusting licensed medical professionals to make determinations of in the best interest of their patient, to include giving them virtual care options when applicable. And so that's another way to make sure that all payers, commercial and public, are robustly covering for telehealth services.
Okay, thank you. There's a question also come in asking around whether the definition of patient changes for 340B purposes if a telehealth visit is used for comprehensive HTC care.
Yeah, I'm afraid I don't know. I'll have to look into that and follow up. I apologize about that.
Okay, thank you. Maybe something else that I can ask you about is, digital literacy and access to digital platforms, things like the internet, computers, smartphones. They're not the same for everybody, right? There are particular challenges that are faced by older people or for people in different socioeconomic circumstances. Are there efforts to increase that access, to make that more available to everybody and to maybe, overcome some of those barriers?
Absolutely. We have to make sure that telehealth is contributing to rectifying some of the great issues that have been exacerbated by the pandemic and that had been in place long before the pandemic. So we have to make sure that it's not just payers covering and reimbursing for telehealth services, to include payers that are available to all Americans like Medicare and Medicaid in certain circumstances. But we also have to make sure that there is that level of understanding as to how to take full advantage of the services. We have to make sure that audio as a modality is offered for all Americans, because even if you're in a broadband area, if you can't afford those devices, you're not going to have access to those services. If you might not know how to navigate online portals, but you do know how to use your phone or you use an app, so you definitely need to be able to do so. And so if we're really going to make sure that nobody's left behind in our healthcare system and that we're plugging gaps, we have to make sure that every American then can have access and know how to access that virtual care option.
Great, thank you. Maybe as a final question, I can ask you to gaze into your crystal ball a little bit. You talked about some important advances that were made during the pandemic and then extended to, at least to the end of 2024. Do you feel optimistic or confident that we're going to continue to go in a direction of greater access, increased telehealth and virtual care? Or is it, how do you feel this may be progressing, or what do you see as the future for this?
I'm extraordinarily confident that we're only at the beginning. And obviously, the pandemic was a dark time for our country and for the world. And it was something that we'll never forget. The ability to expand access to virtual care services, often called the silver lining of the pandemic, of the dark clouds of the pandemic. And most people had only heard of telehealth, maybe at best, prior to the pandemic. Now, the vast bulk of Americans and so many millions, if not billions of folks around the world besides, have had access to those services now. During the pandemic, they've had a taste of the forbidden fruit. For whatever reason, it wasn't available to them prior to the pandemic, but it has been available since then. They overwhelmingly like it. Providers love having this flexibility to deliver care to patients. they want to make sure that we are able to continue to innovate in this space. So both sides of the encounter are loving the ability to have this access. Most importantly, underlying all of this is that our medical professionals are saying so much can be done via virtual care, via technology now, and a lot more can be done in the future. So you're always going to need a laying of hands of a provider on a patient at a certain point over the space of time and continuum of care. But there's so much more that can be done virtually. It's the best way to make most efficient use of our limited healthcare workforces as we treat ever more patients in an aging population. And so I'm very excited about some of the things that are in store for our community. We're only beginning to really apply robustly, for instance, AI technology. We're only beginning to take advantage of the full amount of data that's being generated by a whole host of devices already created or soon to be created. And so I think we're going to be in a world where more people have more access to better care, bespoke care that will allow for people to live healthier, better, happier lives.
Great. Well, thank you very much. It's a very positive note to end on. I'd like to thank Kyle for taking the time to join us this afternoon. We really appreciate your time and expertise. I'd also like to thank each of you in our audience for joining us. This recorded webinar will be available on Friday, September 29th at hemophilia.org under the Events tab. If you select Past Events, you will find all of our archived webinars there. Also available in the Events tab is the schedule of upcoming webinars in this series. Please join us next week when our friends Dr. Asad Hafar and Dr. Jason Martin from the World Federation of Hemophilia will present an update on the WFH Humanitarian Aid Program. Thank you for joining us this afternoon and have an excellent week.